Goes without saying, very excited that Dr. Davide Martino is presenting the webinar today. He is an associate professor in the Department of Clinical Neurosciences at the University of Calgary and a full member of the Hotchkiss Brain Institute. He is also the director of the Movement Disorders Program at the Department of Clinical Neurosciences. Thank you, Dr. Martino.
Good morning. Thank you, Julian. And it's really a pleasure to have the opportunity to present on this important topic. I will now share my screen. Just give me one moment. Okay. Can you all see my first slide?
Yes, that's fine, Dr. Martino.
Okay, thanks. Okay, so I will be presenting to you today on still rather controversial topic that continues to attract interest from clinicians and researchers, and which also requires quite a bit of further investigation, which is the link between neurodevelopmental disorders like Tourette syndrome and OCD and the clinical entity of PANDAS and PANS. And so I'm going to essentially start from saying a few things about what PANDAS and PANS are, how we define them, what is their relationship to a key pathogen that is believed to be involved in their pathophysiology, and which is Group A Streptococcus. So then I'm going to be discussing what is the relationship between this same pathogen and other pathogens and typical neurodevelopmental disorders like Tourette syndrome and OCD, and what is the involvement of immune mechanisms in these disorders, and if there are any biomarkers that are able to be used to differentiate between PANDAS and Tourette or OCD, and ultimately how this might influence treatment. So I guess just I would just start by saying that there is a relationship between infections and neurodevelopmental disorders, or there may be, because infectious agents, whether bacteria, viruses, or prions, have been implicated to incite many chronic illnesses. A number of examples are peptic ulcers, diabetes, cancer, schizophrenia. And the role in neurological disorders really has begun to garner attention as research continues to show a role of immunological responses and disruption of immunological balance in the pathology and the clinical manifestations of all these disorders. For example, in multiple sclerosis, there are a number of immunological disruptions. It's an immune-mediated condition, and recently a potential inciting role for a pathogen like Epstein-Barr virus, the monovirus, has been resurrected in the literature. Similarly, in schizophrenia, neurodevelopmental disorders, neuroinflammation is believed to be partly a result of some prenatal immune trigger like infections, which might precipitate symptoms in genetically vulnerable individuals. There are certainly conflicting findings on the link between tic disorders, OCD, and strep infections, but it is important to say that rarely will a single factor explain why an individual develops tics or obsessive compulsive symptoms. There are likely multiple neurobiological underpinnings at play, and none will act in isolation, but will rather interact with the individual's unique genetic makeup, neural development, and environmental insults on the brain and several immune challenges. So what are PANDAS and PANS, and what are their relationship with Group A Strep? So Group A Streptococcus, as you probably know, is the most common cause of bacterial pharyngitis or pharyngotonsillitis. It is a very common pathogen in the general population with different endemic levels across the world. But it does cause a number of immune-mediated consequences that affect different types of organs, including the brain. And the typical neurological sequelae of Group A Strep is rheumatic fever, which can present also with involuntary movements, mainly chorea. And for a long time, this has been labeled as Sunvitus's dance, or rheumatic chorea. Throughout the 20th century, there have been a few reports indicating that that tics or even obsessions and compulsions and other behavioral changes occur in people with symbiosis dens, with Sydenham's chorea, but it was all considered, these symptoms were all considered to be part and parcel of rheumatic fever. It was only since the mid-1980s when researchers noted that patients with Sydenham's chorea often developed obsessive compulsive symptoms. Later on, though, some clinicians noted that some patients who had just had a Group A strep infection, but who did not develop Sydenham's chorea, presented with acute obsessive compulsive symptoms. And this is around the time when Dr. Louise Kiesling at Brown University in Providence reported on an association between tics and streptococcal outbreaks in her developmental pediatric practice. So based on these observations and reports, researchers from the National Institutes of Mental Health, led by Dr. Swedo, characterized these observations into what we call PANDAS, or pediatric autoimmune neuropsychiatric disorders associated with Streptococcus. They described the first 50 patients, and they reported that in 44% of cases, there was a streptococcal infection just before the onset of this acute obsessive compulsive symptoms or tics. And another 28% just had a pharyngitis, which is non-streptococcal. And further on, they also noticed that subsequent exacerbations of symptoms, of neuropsychiatric symptoms, were also associated with new infection to Group A strep or other pharyngitis or upper respiratory tract infections. So this led to the idea that a distinct subset of children with tics and obsessive compulsive symptoms can develop this condition secondary to an infection. So how do we diagnose, or how typically, classically, is PANDAS diagnosed? It is diagnosed by the presence, by sort of the very abrupt onset or worsening of obsessive compulsive symptoms or tics, or both, by a pediatric onset. Typically, this happens in the prepubertal period. It may have a waxing and waning or a clearly episodic course later on. And this, there should be an association of the onset or other further exacerbations with streptococcal infections documented. And there may also be other neurological abnormalities like hyperactivity or unusual jerky movements that resemble chorea, in fact are called choreiform, that are not in the child's control. What is the actual link between Group A Streptococcus and this acute condition? Well, the interesting part of the literature that has come through after the description of PANDAS is that when kids with a diagnosis of PANDAS were followed up over time, further worsening, further exacerbations of obsessive compulsive symptoms or tics appeared in general not related to new Group A streptococcal infections, which overall suggested to authors that this infection might play a role at the first onset in the majority of cases, but not so much at subsequent fluctuations of symptoms. However, during the first decade of the 2000s and a bit later on too, clinicians started to exchange experiences and started noticing that the definition of PANDAS, as it was originally proposed at the end of the 90s, was not really standing, because probably this spectrum was more complex than originally thought. What came out from these discussions that mostly occurred in the US was that really the entity that they were looking at essentially consisted of very severe and abrupt onset of obsessive compulsive symptoms, which were really the key feature here. Sometimes the onset was overnight, with or without tics. But definitely, there was a lot of variability across studies and across different specialty clinics. First of all, because as we saw, not all patients show a clear, history of Group A strep at illness onset, let alone at even less at future exacerbations. Obviously, given the centrality of obsessive-compulsive symptoms, OCD clinics were more likely to see possible PANDAS than TIC clinics. And also, the typical inflammatory markers that one would look for in trying to link an infection to these acute neuropsychiatric symptoms could be confounded by the fact that once an acute inflammation occurs, there may be changes in the immune system that may lead to a chronic low-grade inflammation that still keeps these markers elevated. So, in other words, there was a problem that blood tests could not time link infections to symptoms in a reliable way. So gradually, particularly due to the limitations of the associations with the streptococcal infection, the PANDAS spectrum was transformed into the PANS spectrum. And PANS is a broader concept that is spelled out as pediatric acute neuropsychiatric symptoms. And the definition is that there is no specific infectious trigger. There's no prepubertal onset. It can happen also after puberty. And tics have been relegated from a primary feature, as in PANDAS, to one of 7 accompanying neuropsychiatric symptom categories. Again, PANS are primarily defined by acute onset obsessive-compulsive symptoms. And later on, there were more studies that clarified that the spectrum was definitely much broader. In fact, typically kids with PANS and PANDAS presented acutely not just with obsessive-compulsive symptoms, but also with separation anxiety to begin with, urinary urgency, hyperactivity, impulsivity, an important deterioration in handwriting and a decline in school performance. You can see in these drawings the pre and post. So this is these are pairs of drawing coming from the same individuals before and after the onset of PANS. And as you can see, it's a sudden deterioration that seems to be occurring in fine motor skills as well as in behavior. For example, speech. Some of these kids may regress to baby talk or even mutism, or experience a new onset of stuttering. So this is actually the broader spectrum of what we mean and define as PANS. And there have been cluster analyses that have described different blocks of symptoms that tend to co-aggregate. The typical cluster is cluster 1 on this slide, which brings together emotional lability, anxiety, sleep disruption, decline of school performance, and behavioral regression, whereas a second cluster combines urinary symptoms, ADHD, handwriting decline, sensory problems, and simple tics. And the most bothersome is cluster 3, that leads to a further lowering of quality of life, which involves eating behavior anomalies or food restriction, as well alongside pupil dilatation, fatigue, GI problems, depression, some psychotic symptoms even, and complex tics. More recently, sleep disruption has been added to the picture, mostly in the form of dream enactment. It was, regardless of the fact that PANS did not require an infectious trigger, it was seen by case series that the onset of PANS was, in the vast majority of cases, in any case related to a recent infection. The further course appeared to be somewhat relapsing remitting, and there was also an important family history of a number of different conditions, including neurodevelopmental, neuropsychiatric, and autoimmune. There is no doubt that PANS and PANDAS cause caregiver burden. More than half of the caregivers of patients of these kids score above a threshold that is used to determine a need for respite, and that this may improve if patients are assessed in multidisciplinary clinics with expertise in this presentation. These PANS clinics have started to come up in North America, particularly in the US. Unsurprisingly, given that they present with obsessive compulsive symptoms, initial imaging studies showed abnormal structures and functions in the same brain regions that control motion and emotion in neurodevelopmental disorders like childhood onset OCD or Tourette syndrome. So this is the picture of PANS and PANDAS, but what is the relationship between strep and the classical neurodevelopmental disorders, which do not have an acute onset, like Tourette and OCD? Well, interestingly enough, these are initial studies that were done about 20 years ago. If you take an X number of patients with Tourette or OCD, and you test for the streptococcal markers, like the most common one is the ASO titers, so streptococcal antibodies in the serum, you can find that between 40 and 60% of these kids have raised titers. Now, this is in cross-sectional studies. Prospective studies also showed that kids who had a chronic elevation of these anti-strep antibodies were more likely to have more fluctuations in the severity of tics and obsessive compulsive symptoms. But overall, elevation of these anti-strep antibodies do not necessarily mean, if they are observed in a single point in time, or if they are chronically elevated, they do not mean that patients are continuously being infected by strep, but simply that they have they've encountered this pathogen previously, and that for some reason their immune responses are boosted up and they produce more antibodies against strep. So we needed to have a different approach to see whether the first onset of tics in Tourette syndrome could be associated with Group A Streptococcal infections. And this is what we did with a European multi-center tics in children study, where we really followed up over time a large number of unaffected siblings of kids with Tourette syndrome, or during vulnerable ages, so between 4 and 10, and for 3 years. And we captured through this time 61 new onset of tics in these previously unaffected siblings in real time, and we looked for associations with recent Group A streptococcal exposures defined in different ways, and we didn't find any clear association with tick onset, which obviously kind of almost seals the concept that when there's a new onset, which is typical of tics in a kid, there's not really a strong rationale to test for Group A streptococcal infection if the onset has been a classical, typical onset of tics, not dramatic and abrupt. Population-based studies, epidemiological studies, also provided some information on this particular topic. Some of the best registries or public health databases that are available in the world come from Scandinavia, and these are Danish registries. And then this interesting study found that a previous record of one or more positive rapid antigen diagnostic tests for strep was associated with a 51% significantly higher risk of OCD diagnosis, independent on the age at the first positive test. However, and this is what I find very interesting in this study, is that even individuals who had a non-streptococcal throat infection, so caused by viruses or other pathogens, also had about 30% significantly higher risk of having OCD, which suggests that the diagnosis of OCD may be not specifically associated with a postnatal exposure to different pathogens or different immune triggers, or simply to an increased vulnerability to infections, rather than just being specific for Streptococcus. And so again, for chronic tick disorders, we wanted to test the same concept, and but this time assessing course. So we took more than 700 kids who had an established diagnosis of Tourette syndrome. We followed them up for 16 months over time with adequate intense follow-up. And we were able to capture 409 clinically relevant exacerbation events of tics in real time. And again, we looked at their association with different definitions of Group A streptococcal exposure, from a most lenient definition to a most restrictive and rigid definition. The bottom line is that we did not detect any association between any of these Group A strep exposures and changes in tic severity or obsessive compulsive symptom severity. However, we did notice that the most lenient definition of Group A strep exposure were associated with an approximately 20% increase in severity of hyperactivity, impulsivity symptoms, which is not surprising if even in Sydenham's chorea, which is the post-streptococcal disorder by excellence, we can find hyperactivity. So in other words, again, the take-home message of this study is that if we have a patient with typical Tourette or persistent tic disorder who is experiencing an exacerbation that it's even intense and clinically relevant, at the moment there is no real rationale to screen for streptococcal exposure, unless obviously the patient presents symptoms of pharyngitis, but you would probably screen for that anyway. This is another study from the MTICS cohort that showed a potential association between antibodies produced to another pathogen that has been linked to other autoimmune neuropsychiatric symptoms, which is Mycoplasma pneumoniae, which is a respiratory tract pathogen, which was found to be associated with higher tic severity in people with persistent tic disorders. Again, this doesn't prove that there's a causative effect of this pathogen in Tourette, but rather that there is a propensity in these kids towards enhanced immune responses and possibly infection and greater tic severity are linked via shared underlying immune mechanisms. We cannot forget about stress or psychosocial stress, because psychosocial stress influences are important because they modulate immune responses, and they even modulate, of course, hormonal stress responses, and may even lead to an increased rate of infections, as we know. And we know that the greatest short-term predictor of changes, of increases in severity for tics and obsessive compulsive symptoms in people who have these chronic conditions is psychosocial stress. There may be an interaction between some infections and stress, but by and large, psychological stress is the greatest influence, it's the greatest predictor on the short term of changes in severity of these symptoms. And this is important because, as I mentioned, psychosocial stress can influence immune responses. So this gradually leads us to the question, if the association between infections and these neurodevelopmental disorders, Tourette, OCD, and ADHD, is non-specific, could this be the result of immune mechanisms that are abnormal, rather than simply an influence of infections on these neurodevelopmental disorders? Now, a good part of the reason for this, for any found association between infections and tics or OCD, is the fact that the immune system in these conditions may be programmed to respond excessively to infections because it is dysregulated or it's hyperactive. And you may be or may not be surprised to hear that maybe this is due in part to the patient's genetic makeup. It is in fact interesting to notice that the various genome-wide association studies that have been conducted in Tourette, for instance, found also a link with genes that control the interactions between immune cells and brain cells. And an example of this is the FLT3 gene. Another important genetic finding is that there is a similarity between the genetic background of Tourette and ADHD and several immune-mediated diseases, including several allergies. As you may remember, people with Tourette and ADHD have a greater rate of allergies than the general population. So we could even say that from a genetic standpoint, Tourette, OCD, and ADHD are to some extent predisposed to have a dysregulated immunity. We all know that these conditions are caused by an abnormal maturation in the trajectory of development of specific circuits in the brain, particularly the circuits which control motion and emotion, the cortico-basal ganglia circuits, and different loops of these circuits control different symptom dimensions. But what is really interesting is that neural development and immune development, they co-occur during the general development of an individual. These abnormal maturations of circuits stems from something going awry through development in different mechanisms like neurogenesis, neuronal migration, synaptic formation, synaptic pruning, and fine-tuning. And interestingly, one of the most important modulators during development in the brain of synaptic pruning and circuit formation is microglia, which is the official brain resident immune cell. So immune system development also happens at the same time, as I mentioned, than these crucial events throughout neural development. So it is definitely possible that in these patients, there may be an abnormal, very early abnormal priming of the immune system, which could depend on gene expression profiles, could depend on an immune modulation that even comes from the mother, even in utero. There is transplacental immune modulation. And of course, may also be due to exposures to other potential hits that trigger the immune responses during postnatal life. And examples of these, obviously, may be psychosocial stressors and infections more than anything else. In line with all this, when we measure directly immune markers in people with persistent tic disorders and OCD, we find typically hyperactive immune inflammatory responses, regardless or not they had a recent infection. And these changes are, for example, an increase in pro-inflammatory cytokines, a decreased number of T regulatory lymphocytes, which is an abnormality that can predispose to autoimmunity, and also a dysregulation of the synthesis of antibodies, as well as an overactivation of cell-mediated responses. So just take 100 patients with tics and OCD, measure their immune markers in the blood, you will see a significant difference in the titers of pro-inflammatory immune markers, which are data that have been consistently reported in the literature. And even epidemiology supports this model of immune hits influencing development of these disorders. In particular, maternal autoimmune disease, so basically the presence of an autoimmune condition in the mother during pregnancy has been found, and this is a meta-analysis, to be an independent risk factor for the development of autism, ADHD, and Tourette. And you can say, you can make similar comments also on metabolic conditions like obesity or other demographic factors, which can all influence on immune competence. For example, low socioeconomic status has also been found. So mothers with low socioeconomic status are twice as likely to have a child with ADHD or Tourette than are mothers with middle or high socioeconomic status. Okay, so biomarkers. Do we have biomarkers that in the presence of a new onset of tics, which is dubious as is whether it's traumatic or typical, or in the presence of an exacerbation of tics or obsessive compulsive symptoms that can help us differentiate between PANDAS and Tourette. Now, the classic theory to explain how PANS or PANDAS occur during the past 25 years has been the so-called molecular mimicry. Molecular mimicry occurs when antibodies that are intended to target an inciting microbe, like strep, at the same time target proteins of our organism, so self-antigens, self-proteins. For Group A strep, this mechanism may contribute to the development of rheumatic fever. And this has been kind of not really fully demonstrated, but there's a lot of evidence in support of this. Some authors have suggested that it is antibodies targeting sugar molecules on the surface of streptococcal cells that can also target human brain cells. And the result of that could be an abnormal release of a neurotransmitter, dopamine, in the brain, which may eventually lead to clinical symptoms. But whether we do have a truly reliable biomarker to test for this mechanism in real patients, it remains controversial. So in order to test for the presence of a mechanism linking Group A strep infection to a brain insult, as I mentioned at the beginning, it is not sufficient just to measure anti-streptococcal antibodies in the peripheral blood, because as I said before, these antibodies simply tell us that the immune system of the individual has previously encountered strep, but not that this encounter has led to a brain insult. So we need other sets of antibodies that tap on a presumed disease mechanism that can cause movement disorders or behavioral disorders. And so a number of these antibody markers have been organized in a panel, which has been commercialized. It's called Cunningham panel. I have no conflict of interest related to this panel whatsoever. I've never participated to its development or its commercialization. This panel encompasses antibodies that target dopamine receptors, D1 and D2, but also a glycolipid of the brain, lysoganglioside, GM1, and then a cytoskeletal protein of neurons, tubulin. And they also involve a functional assay that it's called CAMK2. It's a protein kinase that is important in the synthesis of dopamine. So all these antibodies really pooled in this panel test the function, test the effect of antibodies towards the dopaminergic synapse. So this is a study, a multi-center study conducted in the US on 58 patients with PANDAS or PANS. And what they found was that within this panel, in particular, the CAMK2 assay was the component of the panel that could be associated with a response in PANDAS patients to immunomodulatory treatment. So within treatment responders, CAMK2 activity went down after treatment, indicating a potential indicating that this CAMK2 activity is a potential marker of treatment responsiveness in PANDAS. However, there's another study from Sweden that assessed the diagnostic accuracy of the same panel to differentiate between PANS or PANDAS and no PANS or PANDAS. And unfortunately, the result of this study, which is similarly powered as the other one that I mentioned, this is not a study that tested treatment responsiveness, but tested the ability of the panel to differentiate between PANDAS and non-PANDAS. And as you can see, the accuracy properties of this panel are definitely suboptimal. Really, they are highly variable, and particularly the positive and negative predictive values are quite low. So there is definitely a suboptimal accuracy of the Cunningham panel in discriminating between subjects with and without PANDAS. So why is that? So the problem, there may be different reasons why there's also so much discrepancy about the value of the Cunningham panel. Probably one of the main reasons is that still the clinical definition of PANS or PANDAS is not too reliable. So it is possible that the Swedish authors looked at called PANS or PANDAS patients who presented differently from the US authors. And there, if you look at the literature, there is an interesting dichotomy between US and non-US literature with regards to the way that PANS and PANDAS are recognized and managed and treated. And so, in my opinion, a global task force should be formed to overcome this issue and to finally obtain useful and conclusive results on the clinical diagnostic criteria of PANS and PANDAS, and how and which is the value of biomarkers to diagnose them and follow them up over time. Ultimately, how does all this influence treatment, which is obviously something we all want to know? In fact, if we stick to the evidence, to evidence-based medicine, all this doesn't influence treatment that much, because evidence continues to be uncertain. If we stick to the evidence, the best way to treat patients with PANS and PANDAS is essentially using the same weapons that are used in the standard of care practice for patients with garden variety Tourette or OCD. Antibiotics have been tested, obviously. Of course, if there is an infection, you need to treat the infection, and this is regardless of whether there is a set of neuropsychiatric symptoms associated with the infection. But if studies that looked at the efficacy of antibiotics to treat these neuropsychiatric symptoms, well, they are inconclusive to say the least. And we need new studies to establish the efficacy of individual antibiotics. Antibiotics are very interesting, and not all antibiotics. Some antibiotics, like the beta-lactams, like amoxicillin, ampicillin, and similar, are very interesting molecules because they don't just kill bacteria, they also modulate immune responses. They can reduce the production of pro-inflammatory cytokines, which is interestingly also an effect of some antidepressants like SSRIs. They can also boost the synthesis of serotonin, which we know is quite relevant in emotional regulation. And they can even have neuroprotective effects. Adenotonsillectomy has clearly demonstrated no efficacy, no benefit in helping the severity of neuropsychiatric symptoms in the context of a suspected case of PANS or PANDAS. What about immunomodulatory treatments like intravenous immunoglobulins, IVIG, or others like steroids or plasma exchange? Well, again, if we look at the evidence, unfortunately, and there have been systematic reviews and even meta-analysis that have shown that there is no evidence supporting a superiority to placebo of IVIG in the treatment of obsessive-compulsive symptoms in the context of PANS or PANDAS. The most recent randomized control trial was negative. But there is no doubt that the vast majority of reports that show benefit from these immunomodulatory treatments are open label or small case series, and therefore are not high quality, which doesn't mean that in a proportion of kids with severe PANDAS or PANS, immunomodulatory treatments may not be helpful. They might. It's just that the evidence should be labeled as low quality. There are also, some of these reports are also confounded by the clinical diagnosis problem that I already mentioned, by the fact that symptoms would in any case fluctuate even without treatment in some cases, and by the fact that some of these patients received IVIG or steroids or plasma exchange, but also received antidepressants. Also, some of them had access even to behavioral therapy. So the use of combination therapy confounds our interpretation of effect. So in other words, we need more controlled studies to evaluate the relative efficacy of different treatment approaches and consolidate a treatment algorithm for this acute onset neuropsychiatric spectrum. And 2 slides just to summarize the key points I wanted to make today. Several associations between patients with infections, particularly Group A Strep, and subsequent Tourette and OCD symptoms have been established in population-based studies, but also service-based studies, suggesting at least that there may be a non-specific role of infections in a subgroup of people with tics or OCD. In the late 1990s, an entity called PANDAS has been characterized at the National Institutes of Mental Health, and subsequently a broader spectrum named PANS has been proposed, which encompasses phenotypes dominated by obsessive-compulsive symptoms or other behavioral abnormalities, and includes tics as accompanying feature. PANS are defined by the temporal course, but are not limited to post-infectious causes. Children with PANDAS or PANS, by definition, have a dramatic onset or an overnight onset of neuropsychiatric symptoms. Group A strep infections do not seem to be a major determinant of tic exacerbations or onset, however, in typical Tourette syndrome, although we cannot exclude that there may be a potential interaction with psychosocial stress, which is something, by the way, that we are still looking at in the large MTICS cohort that I mentioned earlier. And the role of other pathogens in influencing course and onset of tic disorders remains uncertain to date. And the last point is probably the one that I think is most important. The complex interaction of patient-specific attributes, which are neurochemical or immune vulnerability genes leading to maladaptive neuropsychiatric or immune function, with environmental attributes like psychosocial stressors, injuries, exposure to substances, or specific properties of pathogens, create an interesting and ongoing research challenge that is currently being investigated in order to understand better the complexity of the causes of these common neurodevelopmental disorders that we are all interested in. And with this, I thank you very much for your attention.
Wonderful. Thank you, Dr. Martino, for that fascinating presentation. At this juncture, at this point, I would ask attendees, if you have your questions, please pose them in chat. And whilst you're doing that, I will just launch the post evaluation. Find it. I'm presuming, Dr. Martino, someone wanted to actually unmute themselves and ask you a question, because there's so few of us, that wouldn't be an issue either.
I mean, I guess if anyone has any direct experience of, yeah, okay, there's a question from Shannon about where do we go from here for treatment? Yes, we definitely need to ask clinicians and researchers to produce evidence-based guidelines, but obviously it would be really sterile just to wait for studies that are also difficult to do, and therefore they're not really available also because of this. I think that a sensible approach, if the question refers to PANS or PANDAS, obviously, I imagine, the sensible approach would be to gauge the treatment approach by the severity of symptoms. So I would not jump onto immunomodulatory treatments without having tried first symptomatic treatments with medications. Sometimes the acute course and the severity of the course does not make these kids suitable to engage into behavioral treatments. But in most cases, we need to try symptomatic treatments first, antidepressants or whatever other symptomatic therapy would be useful to try, depending on the individual case. Keeping in mind that antidepressants in particular also have immunomodulatory properties, so they can also help the immune system. If the severity increases, worsens, despite an initial trial of typical standard of care symptomatic treatments, I would then consider consulting a specialist immediately, a rheumatologist, or even better, a neurologist or a psychiatrist. And in some of these situations, hospitalization would be useful because it would also open the opportunity to empirical treatment with immunomodulatory options like IVIG or steroids, or even plasma exchange at a later stage. So judging by severity, I think it's what we really need to do in these situations. There's another comment I really stress the sudden onset of symptoms, but our experience has been when all 18 when things started. So yeah, the sudden onset. So the experience, I'm not sure how different was the experience based on Tatiana's message. And because of the age, yeah, I mean, like PANS, Tatiana is saying one of the hurdles in getting adequate treatment and being considered for diagnosis and management is the relatively old age of onset, 18. Well, the PANS, the P for PANS stands for pediatric. So in theory, this does not, an 18-year-old does not fall or qualify within the pediatric realm, but I don't think that if the phenomenology is the same, or is in some way reminiscent or reflective of PANS, then I would believe that the treatment, the management should be exactly the same. The only difference is that you need to rely on adult specialists as opposed to child specialists. But again, the specialties should be the same, neurology and psychiatry primarily. And again, I don't have any other detail on the specific course, but or I don't know what was told to you, Tatiana, with regards to why it was difficult to diagnose and treat at an age of 18. Oh yeah, I mean, people are not interested. People are always are interested. That often specialists are just simply caught on the spot and put on the spot on conditions that they have never seen. And I myself haven't seen a great deal of PANS or PANDAS in my whole life because I think they are relatively uncommon entities. And I'm sure this is shared by the majority of my colleagues who work in child as well as with young adults in neurology and psychiatry. So lack of interest is sometimes is a shield that protects from lack of experience in managing these conditions. Yeah, there are psychiatrists and there are also non-psychiatrists, rheumatologists in Calgary who work with PANS. I mostly know rheumatologists actually who do that, and I would love to have a better crosstalk with their clinic as well. I understand that there is an in-progress multidisciplinary clinic here at the Children's, and which has been established only very recently. I'm not sure what is that. I don't know what that.
Not sure what that relates to exactly.
Okay. But in any case, I think that I totally agree. There should be a more systematic. There should be a systematic approach to these unusual cases. They should be seen ideally within the same outpatient or even inpatient clinical services, possibly by the same team, which should be multidisciplinary. That is the general idea. How many cases will present to hospital in 1 year? This is really hard to tell. I don't expect a large number of cases. And in fact, even in the US, there's only a handful, or maybe not a handful, but quite few PANS multidisciplinary clinics across the country.